Hi, good morning everyone. It's a pleasure being here today, and I'm quite happy to see so many of you here today for our public forum. I'm Dr. Darren Goh, consultant urologist from Changi General Hospital. I did a one-year fellowship training in London, UK, doing prostate cancer surgery. And today I'll be talking to you about prostate cancer and treatment options. So you've heard from Dr. Kenneth Chen regarding the risk factors, signs and symptoms, and how we diagnose prostate cancer. So when the patient comes to us in the clinic, usually we have to give the bad news about the diagnosis of prostate cancer. Typically, you'll get a wide range of emotions from patients. Most commonly, they will tell us that they have no symptoms, they feel all right. As Dr. Chen said earlier, that most of the prostate cancer early stage are silent. Sometimes patients ask us, why is it him? Some of them are in denial and some show some anger. Once the emotions settle, then what next? We have to discuss with the patient. They need to understand the disease in general, understanding an individual's disease. No two prostate cancers are the same, and we have to individualize the treatment. And then we'll discuss what are the treatment options available. So usually when we tell them there's a prostate cancer, some of the common questions they are asked: how common is it? Why is it me? How will I be affected and will I die from it? And what can I expect now in terms of investigations as well as treatment available? So you all have seen these slides quite a few times this morning, so I won't be going through it too long. But basically, prostate cancer, as we already know, is the third most common cancer in Singapore males. This is taken from the Singapore Cancer Registry. And what we have found is that over the past 40 years, two main cancers have incidents have risen sharply in the past 40 years. For the females, that's going to be breast cancer, and for the males, it's going to be prostate cancer. All right. So yes, risen fivefold from about 6 per 100,000 to 30 per 100,000 males in Singapore. And to put it into perspective, 1 in 7 cancers in men is from the prostate. The next logical question is, will I die from it? As Professor Ng said earlier, cancer that is frequent and kills is important. Prostate cancer is frequent, but thankfully it's not as lethal as lung cancer or colorectal cancer. All right, it's the 6th most frequent cause of death in Singapore male. All right, but it is still important nevertheless. We compare to worldwide, Singaporeans like to be number 1, but I think in terms of cancer, I think we can aim to be lower. So basically the green covers mainly Asian countries. Singapore is somewhere below. Same for mortality rates as well. We are basically somewhere below. And all these are basically risk factors that are uncontrollable. It's mainly due to the race. African males, blacks, they tend to have higher risk of prostate cancer and dying from it as well. So what will we do next now? For most cancers in the body, we will aim to do what I call cancer staging. We want to know whether is it early or late stage. That makes a difference to the kind of treatment options available. The other thing that we like to do is to have a rough idea of how serious the cancer is, how aggressive the cancer is. So we do a kind of risk stratification to find out is it a low, intermediate, or high risk. This determines the likelihood of progression, the likelihood of the cancer spreading to other parts of the body. So broadly, to divide up the prostate cancer staging, 4 stages. Stages 1 and 2 typically is a localized cancer, and stages 3 and 4 is when the cancer starts extending beyond the prostate and spreading to the surrounding structures or to distant organs. So as you can imagine, the higher stage the disease is, the worse the prognosis is going to be. I'm putting out this table mainly to just highlight the fact that nowadays many patients are going for PSA testing, whether it's part of health screening or just the greater awareness of the disease. And most of the cancers nowadays are based on what we call T1C disease, where we are diagnosed based on a trust biopsy due to abnormal PSA. The red line basically demarcates generally the early stage cancer versus the late stage cancer. Okay, so to reach the diagnosis of prostate cancer, most men will have undergone a digital rectal examination. Rest assured, we are usually not smiling when we are doing the examination. Okay. Of course, the DRE is really to look for any obvious nodules in the prostate, the size of the prostate, and the consistency of it. And following that, typically we will need some other investigations depending on your urologist. Common investigations include MRI prostate or CT scan of the abdomen and pelvis. We do bone scans as well because if the prostate cancer is to spread, the most common area of spread is to the bones. There might be other modalities available such as PET scan. This really is probably not necessary in all cases and really would be up to your doctor to decide on which is the best modality for you. So we want to risk stratify the disease. We want to know how aggressive the prostate cancer is. All right. So prostate cancer, they're all not the same. All right. We want to know whether is the prostate cancer not so aggressive like a kitten or whether it's aggressive like a tiger. All right. And how do we do that? We usually use three main parameters to decide, which is our PSA level, the Gleason score, as well as the digital rectal examination. So basically, to put it simply on two extremes, okay, a low PSA level, a low Gleason score, and a normal digital rectal examination would likely put a patient at a low risk kind of category, whereas the opposite is true. A high PSA with a high Gleason score of 10, abnormal digital rectal examination with nodules on the prostate would typically put a patient at higher risk. And this really impacts on the patient's treatment options, impacts on the patient's prognosis as well. So for staging and basically an overview of the staging and treatment, all right, I would like to divide it into two main categories, the early stage as well as the late stage cancer. So early stage cancer, stages 1 and 2, our aim is to cure of the prostate cancer, and the main three options available would be observation, surgery, and radiotherapy. For the advanced stage, usually we aim to relieve symptoms. We aim to delay disease progression. And here we are talking about non-surgical options such as hormonal therapy or what we call androgen deprivation therapy. There's a role for chemotherapy and other newer agents as well. All right. Of course, not all medical science is not all black and white. There are patients who are going to be somewhere in the middle where they might benefit from a bit of both. All right. So basically it's not one-size-fits-all kind of treatment options. So to talk about early prostate cancer, as mentioned, so observation, surgery, and radiotherapy. I'll talk about what we do usually. What urologists do would be to do surgery, and this is what we term radical prostatectomy. What it simply implies is that, so if you look at the diagram, this is where the bladder, this is your prostate, urethra, and the urinary sphincter. So to put it simply, what we do is that we will cut away the prostate, and then we will join the urethra to the bladder over a urinary catheter. There are some nerves and blood vessels that run by the side of the prostate, which may or may not be affected during the operation. And this has a direct impact on what are the side effects of surgery, which typically includes things like urinary incontinence, as well as erectile dysfunction. The prostate cancer surgery and the disease itself came into more prominence over the past few years because there has been famous politicians in Singapore whom you're probably familiar with. So they've had prostate cancer surgery, they have recovered well from it. So I think it's something that is easily treatable and curable. And usually in the past, maybe 20, 30 years ago, we used to do it either open surgery or by keyhole, laparoscopically, all right? But in the past 15, 20 years, with the new robotic system, we are doing what we call robotic surgery. And more than one patient have asked me when I told him that we do it robotically. The impression that they get is that, oh yes, you're getting a robot, and then we just press a button, we just take a cup of coffee, relax, and just watch the robot do its work, all right? Thankfully, that's not the case. All right, so I think we've shown this slide earlier. We use what we call robotic-assisted radical prostatectomy. So rest assured, we are somewhere here, near you. Okay, we are not in the coffee room. All right, we basically use the robotic arms which are inserted into the patient's abdominal cavity, and basically the robotic arms allow us to have a very good range of movements within the abdominal cavity for the operation. This gives us really very good, better control, better precision in doing the surgery. Of course, surgery being a surgery, there are potential complications. So it's under general anesthesia, so there's an inherent risk of anesthetic complications such as heart attack and stroke. In terms of the surgery itself, the three main things that we usually want to worry about would be urinary incontinence, erectile dysfunction, as well as cancer recurrence. All right, urinary incontinence. Typically, patients within the first couple of months they do get a bit of urinary incontinence, but generally speaking, it actually improves over time, and most of our patients actually do fairly well with very minimal leakage. Erectile dysfunction would be usually due to the nerves that are affected that runs by the side of the prostate. So again, if we do nerve sparing kind of surgery, there is a fairly good chance that we can preserve some erectile function, and the rest can actually be treated with medications. The main aim of any cancer surgery is to prevent cancer recurrence. So this is our aim, is to prevent any cancer recurrence. I mean, but sometimes based on disease profile, some patients, if they do develop recurrence or they have a high kind of a disease profile, high-risk disease profile, they may need adjuvant treatment. And this is what I will talk about later in terms of radiotherapy as well as hormonal therapy. Okay. Other complications would be usually what typical ones related with surgery: bleeding, infection, injury to nearby structures, and lymphedema if we do some lymph node dissection. If patient undergoes surgery, what do they expect after operation? Typically, the hospital stay will be a few days. If everything goes well, they expect a surgical drain to be placed post-operatively. This usually is removed after 1 or 2 days. We leave an indwelling urinary catheter to allow for the anastomosis to heal, and we typically keep it for about 7 to 14 days. Some patients may need a specialized X-ray to ensure that the area of operation has healed before we remove the catheter. We will follow up in the clinic, basically following up on the PSA levels, all right? And again, depending on what the final histology shows on the prostate specimen, patients may need further treatment. So what other treatments are available for early prostate cancer? Okay, this is, of course, radiotherapy. This is done by our oncologist colleagues. So the good thing about radiotherapy is that you avoid surgery. You avoid the risk of anesthesia, you avoid the risk of surgery, all right? It's generally painless, but well, what we get from patients is that it is a bit more cumbersome in the sense that they have to go for frequent treatment options over a prolonged period of time. So it may not suit everybody. Some of them feel very fatigued from going for the radiotherapy sessions. There's two main forms, what they term as external beam radiotherapy, as well as internal or brachytherapy. Right? So this is not within my specialty, but certainly they have many new technology that helps deliver the external beam radiotherapy into the body. All right. Brachytherapy usually implies internal, where they implant some radioactive seeds or needle into the prostate to achieve the radiation dose for the prostate cancer. Certainly, any treatment, there are side effects. So for radiotherapy, typically patients may get urinary tract locally over the area of concern, which is the urinary tract and bowel. So they may get lower urinary tract symptoms, they may get frequency, urgency, they may get blood in the urine, they may get leakage as well, they may get bowel toxicity with change with bowel habits or blood in the stools. Patients may feel fatigue. There is found to have associated slightly higher increased risk in secondary malignancies after radiotherapy. Of course, some patients may also get erectile dysfunction, and typically side effects of radiotherapy may be a bit more late onset, as opposed to surgery, which typically is more immediate after the operation. What if we do nothing about it? All right, so I mentioned earlier, observation is an option. All right, just doing nothing. All right, to decide whether or not we can leave it alone, we need to understand the natural history of prostate cancer. So we know Sun Tzu, the famous quotes, 知己知彼，百战百胜. All right, if we know the enemy, which is the prostate cancer, and we know yourself, then in 100 battles you will not be defeated. What this means is that we need to know the prostate cancer, and what we have found out is that some prostate cancers can be safely left alone. And logically, if you think about it, it's going to be a very low risk kind of prostate cancer, and especially in a patient who have short life expectancy. So if a patient has a very low PSA, low Gleason score, and the patient is 85 years old, 90 years old, sometimes the reasonable thing is not to do anything about it. Because we know that for the prostate cancer to progress and affect the patient's lifestyle, quality of life, causing symptoms, it might take a good 5, 10, 15 years. And this is proven because autopsy studies have shown that many men die with prostate cancer rather than from prostate cancer. So a male 85 years old or 90 years old, well, is usually more likely to die from old age, heart disease, stroke, rather than from the prostate cancer. So why do we want to observe? The main aim is to avoid the side effects. I mentioned about surgery, I mentioned about radiotherapy, and they have potential complications. So if by observing, we are avoiding the side effects of this treatment. If we leave it alone, the downside of it is that there is a chance of disease progression and spread. All right, so it is a risk. And in that sense, a young patient with a prostate cancer, typically we will rather them not observe because they have a long lifespan ahead and there's a higher chance that the disease may progress and spread. The other key thing, of course, is anxiety, all right? If you are an anxious kind of person, then certainly having a prostate cancer inside might not be something a patient can accept. So are you suitable for observation or expected management? Really depends. If you are anxious, then certainly I don't think that's a good option. But if you are relaxed, something that you can consider. Okay, so after we go through the treatment options, typically patients will ask, which is best for me? Which treatment is superior? Which is the best? Okay, so speak to us because again, it's not one treatment that is the best for all. It really depends. All right, we look at a lot of factors to help us decide. Okay, what's the risk like? Is it low risk or high risk? Age of the patient is very important. What are some of the medical conditions? If a patient has a lot of medical problems, that might make surgery high risk, and that we probably wouldn't want to consider that. On the same token, if patient had previous radiotherapy for other conditions, it might make them not suitable for radiotherapy. Patient's mentality is very important. Okay, see what kind of person he is, and whether they want something once-off, quick fix kind of surgery, or whether go through for a slightly more prolonged kind of treatment option. Moving on to advanced disease, all right? So usually when I tell patients that they have prostate cancer, sometimes they say, doctor, I don't want surgery, I don't want radiotherapy, I want medications. Okay, so I will usually tell them that if I can offer surgery, that's actually a good sign. All right, because that means that the disease is early and that we can potentially cure. If we do not even offer surgery, usually we are talking about a later stage kind of a disease state. So there's minimal role for surgery or radiotherapy in this stage. Okay, usually we talk about androgen deprivation therapy, sometimes talk about chemotherapy and other newer agents. Okay, so what is this ADT? This has been studied all the way back in 1941. Charles Hawkins got a Nobel Prize for studying the effect of reducing the testosterone level on the effects of prostate cancer. All right. So basically, what we know is that prostate cancer cells depend on testosterone to grow. Where does testosterone come from? 90% come from the testes, 10% from the adrenal gland. All right. So what the therapy involves will be to reduce the body's testosterone level, and this helps to slow down the growth of prostate cancer cells. Two main ways. One is surgery, all right? We remove the testes, all right? So this is permanent once-off kind of solution, and patient does not require regular medications, regular injections. The downside, of course, is even though this is a minor operation, well, most of the time patients are elderly, so there is still the risk of surgery, anesthetic risk, and of course, emotional distress. No man likes to have the testes removed. All right, so many a times now patients go for easier option, non-surgical option, which is medications. So there are various options available. Most of them are injections, and all this can be talked to by your urologist. This just shows the different levels of where the medications work on in terms of the testosterone. All right. Of course, any treatment does have side effects. So what we are doing is that we are reducing the body's testosterone, and sometimes you get various side effects: fatigue, loss of libido, erectile dysfunction. You can get osteoporosis. You get some metabolic side effects. I may put on some weight, and then cardiovascular risk factors as well. So moving on, if ADT doesn't work, or in some higher risk kind of disease, chemotherapy would be an option. Again, this is in the realm of the oncologists. They give chemotherapy. They can also give one of the newer agents in the market that has been proven to help in patients with advanced prostate cancer. Okay, so I'll just summarize the treatment options available. So broadly speaking, early versus late. Early, 3 options, observation, surgery, and radiotherapy. And in the later stage of a disease, usually we are talking about hormonal therapy or androgen deprivation therapy, and sometimes chemotherapy and other newer agents. So this is my conclusion slide. As we know, prostate cancer is a very common problem, third most common in Singapore males. Okay, but it's not all doom and gloom. It can be indolent because third most common, but 6th most frequent cause of death. Management really depends on the stage of the disease, the risk group, patient factors like the age comorbidities, patient's life expectancy, patient's life expectations. All right, so at the end of the day, if any problems, speak to our urologist and we will answer further questions. That's my last slide. Thank you.